Good morning, everyone. Welcome. My name's Jane Sharman. I'm from the Neurological Foundation, and we're very pleased to have you all here today, particularly as this is our annual appeal week. So just a few housekeeping things to start with. So everybody should have registered on the way in and handed in their registration form. If you didn't, please do so on the way out. That's just really helpful for our numbers and event planning. If you need the bathrooms, they're just out to the left in the foyer there. Please make sure you put your cell phones on silent if you haven't already, or turn them off. One gentleman asked me to just point out that the chairs that you're sitting on actually do have an armrest. So if the armrest isn't down, then please feel free to push that down for your comfort. So the way that this morning is going to run is we're going to have an introduction from Mr. Kevin Milne, who we're very pleased to have here today, and he'll introduce our guest speaker, Dr. Cathy Stinear, who will give you her very interesting presentation. Following that, there'll be a short time for questions and answers with you, the audience. So we'll have some microphones that we'll pass around. So please just be mindful that there are a lot of people here who want to have a say. So just keep your questions quite short. Dr. Stinear will also be around following the lecture if you have any other questions for her. So thank you very much and enjoy.
Well, hello. Can you hear me okay? I don't need two microphones. I hardly need one, actually. It's a great pleasure to be among you all, and what a wonderful turnout. This is fabulous, and it's a terrific, it's terrific support for the Neurological Foundation and for Dr. Cathy Stinear, who's here today. My name's Kevin Milne, and you're probably wondering why I'm not just out selling carpet. I used to be on Fair Go, as you know, but I've moved on from there. I'll tell you why I'm not out selling carpet this morning. A couple of years ago, I found myself with a pituitary tumor, which is sort of a brain disorder of a kind. The pituitary tumor hanging around there, down the, I think down around the bottom of the brain somewhere. Anyway, I had to have this tumor removed because it was threatening to take away my eyesight. We tried to avoid having the big operation, but we couldn't. And so I went into hospital to Wakefield, and this absolutely brilliant brain surgeon with an ear, nose and throat surgeon did this extraordinary operation where they went inside into the middle of my head. After a while, they found a bit of brain and removed the offending tumor and shot a video of the exercise over to New York the next day because they were so proud of the way it had happened. And I was very proud of the way that it happened. I was very proud of them, immensely grateful, naturally. That last year I then got involved with these wonderful people, with the foundation, and travelled around the country with a group of, well, they were brain experts of one sort or another. They were scientists, they were clinicians, they were researchers. I was nervous because I thought a trip around the country with a whole lot of brain surgeons, I may not actually have an awful lot in common with them. And they turned out to be most wonderful, wonderful people. I got home after a couple of weeks of traveling around with them, and a week after I got home, my wife had a brain tumor, had a brain hemorrhage. Totally out of the blue, came home from Pilates, and immediately we were into Wellington Hospital, and she was in the brain ward being looked after by the brain surgeon, or one of the brain surgeons that I'd been involved in was now looking after my wife. So you can imagine that I've got a rather deep affection for these wonderful, wonderful people. This week is the Neurological Foundation's annual Appeal Week, and this event is part of a national lecture series to raise awareness of the critical need for brain research funding. The Neurological Foundation's raised over $40 million to fund brain research in the past 40 years and needs you to help continue with its work. I'd like to make special mention of the 22 years that Mitre 10 has collaborated with the Foundation. They sponsor the Foundation's annual appeal. They pay for the production and print of our appeal envelope, and they help to spread the message across New Zealand. Quite simply, without Mitre 10 and their passionate staff, the Foundation would not be in a position to have Appeal Week. Thank you so much, Mitre 10. They, of course, also supply a lot of the drills and the saws and stuff that the brain surgeons use. I'm only joking. I just made that up. The Neurological Foundation is the only non-government neurological research funding body in New Zealand, and over 98% of our funding comes from donations from the public. The other 2% or so comes from trusts and grant bodies. Funding for brain research is needed more than ever to improve the outcomes for the growing number of New Zealanders being diagnosed with neurological disorders, me and the missus to start with. As our population ages, so too does the number of these disorders. And the only way to end neurological disease is with the best research. Research is making great progress, as you'll find out today from our speaker, Dr. Cathy Stinear. Dr. Cathy Stinear is a prominent stroke neuroscientist at the Centre for Brain Research at the University of Auckland, working with many leading scientists and clinicians, including the Neurological Foundation Chair of Clinical Neurology, Professor Alan Barber. I'm sure many of you know and have heard of him. Her research focuses on translating discoveries in neuroscience into clinical practice with stroke patients, so the best possible recovery can be made. For many years, Dr. Stinear and her colleagues have been studying how the brain's flexibility, its plasticity, helps recovery. She's part of a New Zealand-based team investigating new approaches to rehabilitation following stroke or brain injury. And these approaches show great promise. An important study led by Dr. Stinear was published in the leading journal Lancet Neurology in 2010. In today's lecture, Dr. Stinear will talk about her work and explain how simple movement devices and non-invasive brain stimulation techniques can be used to increase the activity of the stroke-affected side of the brain to help improve movement and recovery. Last year, my meeting and hearing Dr. Stinear, why am I calling it a Cathy, was one of the highlights of our national tour. Please join me in welcoming the very lovely Dr. Cathy Stinear.
Thank you so much for that introduction, Kevin, and thank you to all of you for being here today. It's great to see so many of you out here. Can you all hear me okay? Ah, that's a shame. How about now, if I use my big girl voice? I've got a microphone on so that I can stand and do this, because this is what I like to do when I talk. So is that going to be all right if I speak up? Sort of. Okay, well, we'll make a start and see how we go. So as Kevin said, I'm going to be speaking with you today about some of our research into how we can help to improve the recovery from stroke. So first of all, technology, eh? Here we go. There's the old on-off switch problem. There we go. Not technology error, human error. Sorry about that. So first of all, stroke. Stroke, as many of you know, is actually the most common cause of adult disability worldwide, and there are around 8,000 strokes per year in New Zealand alone. At any point in time, there are around 56,000 people in New Zealand living with the long-term consequences of stroke. And worldwide, 1 in 6 of us will experience a stroke at some point in our lives. Stroke is a very big problem, set to get bigger as our population ages. So what exactly is a stroke? Well, simply it's a loss of blood supply to part of the brain. And this can happen for 2 main reasons. The most common reason is what we call an ischemic stroke. This is where a clot forms somewhere in the body and it travels around in the blood vessels and it goes to the blood vessels to the brain. And the blood vessels get smaller and smaller in size, and so eventually the clot gets stuck. It gets stuck in a blood vessel that it can't move through. And once it's stuck, it blocks the blood flow from that point onwards. So everything downstream of that point is deprived of blood and oxygen, and the cells quickly begin to die within only a couple of minutes. The other kind of stroke is a hemorrhagic stroke, and this is where usually a small blood vessel in the brain bursts. Perhaps the walls have been weakened by some sort of disease, perhaps there's a congenital abnormality, and often high blood pressure contributes to this. So in this case, the blood vessel bursts, so the blood is no longer going to where it needs to be, and again, the tissue downstream quickly begins to die. So this is the one thing that I'd really like you to remember today. If you don't remember a single thing that I have to say, I'm completely fine with that, but try to remember this. This is FAST. This is how to tell if you or someone that you're with is experiencing a stroke. So the F stands for face. If you or the other person tries to smile and one side doesn't work, call an ambulance. A is for arm. If you or the other person can't get both arms to here, or one arm will come up and then drift back down, call an ambulance. It's a common sign of stroke. And S is for speech. If you or the person you're with is struggling, is slurring, the words aren't coming out clearly, or the words won't come at all, call an ambulance. And T is for time. Time is because time is brain, and every minute that goes by means that cells are dying, and once they're gone, they're gone. We can't help once they're gone. Nothing upsets us more in the hospital than people saying, oh yes, this weakness, it started last night, but I didn't want to be a bother. I thought I'd just see my doctor in the morning. And it turns out they've actually had a stroke. And if they'd come straight to hospital, there might have been things we could have done to help. But once a few hours have elapsed, there's very little that anyone can do. So FAST is the thing to take away today, if you don't remember anything else. Face, arm, speech, and time. Okay, time is of the essence because time is brain. So what does stroke look like? Well, here are a few scans from just a handful of people that have been generous enough to take part in our research. And you'll see these are the strokes here. See that little black dot? That area there? This is a tiny, tiny, tiny stroke, right? This was actually surprisingly disabling. This actually weakened the opposite side of the body quite drastically, and this person was quite impaired. Another stroke here. This is a very large stroke. Okay, this person's quite fortunate to have survived that. So you can see that every stroke is a bit different, isn't it? And the size of the stroke actually isn't a very good indicator of how impaired the person becomes. It's more important to think about which parts of the brain have been affected. So the symptoms of stroke depend on exactly which areas of the brain have been damaged. So what happens after stroke? Well, these are some of the really common symptoms experienced by people. Weakness on the opposite side of the body, often a lot of clumsiness as well. You lose that fine motor control. Fatigue is extremely common after stroke. You just have to work so much harder, basically, to achieve ordinary, everyday things. Communication is often affected, as is memory. And not surprisingly, all of these things can result in a bit of loss of confidence for the person. And about a third of people experience depression after stroke, which I think is actually a pretty natural response to what's occurred. What happens particularly for the 3/4 of people who experience weakness is that they don't do as much. They're not as physically active, and this means they lose strength, they lose whatever fitness they had, and it's very easy for them to become physically inactive. The problem with that is that it increases the risk of a second stroke. We know that being physically active decreases your risk of stroke, so becoming inactive increases it. And if a second stroke does occur, this becomes a vicious cycle. Now, I'm particularly interested in the recovery of hand and arm movement. That's my particular area of speciality. So if we think about this for hands and arms, then they're commonly weak, clumsy, and get easily tired after stroke. And often what people do is they compensate for that. Right? Arms aren't like legs. You know, arms, you've got one on the other side that you can do a lot of things with, but to walk, you need both your legs, right? So often people are sort of forced, really, to work a bit harder on recovering their walking, whereas if your hand is quite weak, it's relatively easy just to stop using it and to start using the other side. And the problem with that is that it just becomes another vicious cycle. That weak hand can't get better by doing nothing. The only way it will get better is through practice. So what might this look like in the brain? Well, here's a functional MRI scan of someone in the scanner doing this. They're just opening and closing their right hand. And you can see this little patch here of activity on the left side of the brain. And that's exactly what we expect to see. That's right on the area of the brain that controls the hand. So it's active because the person's doing this. We like to think of this as a completely normal looking scan. I like to think of it as that because that's my brain that you're looking at. So we're going to agree that that's totally normal. Good, okay. So here's someone after a stroke, and they experienced a stroke on the left side of their brain, and they're lying in the scanner doing this with their weaker hand. And you can see that the pattern of activity is quite different. They've got a little bit in roughly the right spot, but they've got a lot of stuff happening on the other side and some stuff up the front that doesn't look quite normal. Now, if we leave that person alone and they just sort of go about their normal business for a month after stroke, this is how their brain changes. It's actually a really big change, isn't it? That's a huge difference in only 1 month. They've got lots more activity in the brain, but it's all on the good side of the brain, not the stroke side. And despite all of this extra activity, they've only made a 10% improvement in their weak hand. Now you might be thinking, well, that's strange. Their brain's working much harder, so how come their hand isn't working any better? Well, the answer is quite simple. Each side of the brain controls the opposite side of the body, as you know. And after stroke, the control by the stroke side of the brain on the weak hand is damaged. So that's why that hand is weak and clumsy. Now, the good side of the brain does have some connections to the bad hand. So this would be the good side, this would be the weak hand. There are some connections, but they only go about as far as your shoulder, or maybe your elbow. There are no connections from the good side of the brain to the stroke hand, none. So that means that all of that extra brain activity on the good side of the brain can't help because that side can't talk to the weak hand. So the only way then that the stroke side of the brain, the only way that the weak hand can recover is if the stroke side of the brain gets better control of that hand. Okay, that's the only way that recovery can take place, for hands at least. So this is the cycle we need to break. We need to get the person to be practicing, to be using their bad hand, to try perhaps using both hands together. This will allow it to improve. Doing nothing certainly won't let it improve. And hopefully that will improve its strength, control, and stamina. So what does the brain look like if this is what the person does? Well, here's me again doing this in the scanner, totally normal. Here's a different person with stroke. You can see that when they squeeze and release with their weak right hand, again, we have a quite abnormal pattern of brain activity. You can see a little bit over here, but most of the action is on the good side of the brain. And as I just explained, that's not really helping the hand. So if we send that person away and they have a month of daily therapy with their weak hand, this is what happens. Big change. That stroke side of the brain becomes much more active, and as a result, they see a much bigger improvement in their weak hand. Okay, so all of the changes you see after stroke in hands and arms and walking and communication, all of that comes from changes in the brain. It's not the hand that changes, it's the brain that changes. How does it change? How do we get from here to here in only a month? That's amazing. It's through a process called plasticity. And the simplest definition of plasticity is it's changes in the number and the strength of connections between neurons in your brain. And it's this plasticity that helps all of us to learn throughout our lives. Everything you know how to do, everything that you remember, everything that makes you, you, is stored in the connections between neurons in your brain. It's a pretty profound thought. And it's the ability for those connections to constantly be changed and shaped. You're doing it right now, right? As you learn any new thing, you're making new connections in your brain. It's a pretty cool thought. This is how we help the brain to relearn from injury, after injury. Okay, it's true that you can teach old dogs new tricks. Plasticity is with you for every day of your life. It never goes away. All right? And it's crucial after brain injury. This is how the brain reorganizes and relearns how to do things that have become difficult after injury. So, plasticity is the magic mechanism. It's not magic, it's actually pretty well understood. And what my research group is interested in is figuring out how to boost the plasticity process to help the brain make new connections, strengthen existing ones, and recover as well as possible after stroke. And the way we're approaching this comes under a general umbrella term called priming. Now, priming is about preparing the brain so that it's more plastic before therapy. Why do we want to do this? Well, one of the reasons is that therapy dose is limited. When you've had a stroke, the amount of therapy you get in rehabilitation has some limitations. And it's not just because, it's partly because, but not only because we don't have enough therapists working in our hospitals and inpatient rehab units. We desperately need more of those talented people. But that's only part of the equation. If you had a stroke and I put a therapy team around you for 8 hours a day, you couldn't do 8 hours of therapy a day. You could maybe achieve 2 to 3 quality hours because fatigue is such an issue. So the amount of therapy that people can complete after stroke has some limitations. What we want to do is think about how can we help the brain be more plastic so that it responds as well as possible to whatever therapy dose it gets, right? Not going to worry about the therapy dose side of the equation, we're going to worry about the brain side of the equation. So that's what we're trying to do, prepare the brain before therapy. And there are 3 main ways that my research group is looking at this. One is with pharmacological agents, so that's using medications that are already in use. Another is with non-invasive brain stimulation. And a third is coordinated movement patterns. And briefly today, I'm just going to outline some of our exciting new results on those last two. The general idea, though, is this. Use coordinated movement, non-invasive brain stimulation, or medication to take the brain, it's clearly inside your head at the time, don't worry about the picture, pre-activate it, make it more plastic, come on, and then engage the person in therapy. Get them to practice the things they currently find difficult with a brain that's more prepared to create new connections and relearn how to do those difficult things better. Right, so one of the ways we've been doing this is with coordinated movement patterns. And this device here that you can see in use, it's a little bit hard to tell from a still, but basically the patient puts their hands in it, and by moving their good hand back and forth like so, through a mechanism underneath, that drives the weak hand in a mirror symmetric pattern. And now you might be thinking, Cathy, this doesn't look that useful. Unless you make a living out of waving to people, you know, the Queen maybe, I don't know. You know, this is not a useful movement. And you're right, this is not a useful movement, but we chose it for some very particular reasons. What it does is by driving that weak hand back and forth is it creates lots of sensation, creates lots of sensory information that goes up to the stroke side of the brain, and we know that that pre-activates that stroke side of the brain. You might be thinking, well, can I just do this? Can I sit there and just move my own hand back and forth? And the answer is, well, no, for a couple of reasons. One is that you need around 1,000 repetitions. It's a lot. And so what the device does is, because it's very low friction, it's easy. It's actually pretty effortless to just drive it back and forth, easy peasy. Most people in 15 minutes will achieve 1,200 repetitions without much effort. The other thing is that the pattern is a bit special. This works, this does not, okay? And there's a reason for that. How many of you can do this? Give it a go. I've had to practice so I can give this talk. Yes, you can. Yeah, nice. Okay. So the reason that you can do two separate things with your two hands at once is because the movement areas on each side of the brain are capable of ignoring the other side, right? They can go, no, 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 don't confuse me. I'm going to pat. You do circles and I will pat, right? Have you noticed how little kids can't do this? They end up here or here, right? And that's because the connections between the two sides of the brain aren't mature yet. They don't mature until you're about 10, 18, 12 years old, something like that. So little kids really struggle with that, right? So those connections between the two sides of the brain are really important. When you're doing two separate things, each side puts the brakes on and goes, no, no, don't talk to me. No, don't confuse me. I need to do my own thing. But when you're doing the same thing, the two sides talk to each other, right? This is the same thing, right? I'm bending my wrists, flexing them at the same time, extending them at the same time. So because both sides are doing the same thing at once, the brakes come off. You don't need them. You don't need to ignore the other side. And what that means is that the stroke side of the brain gets the brakes taken off it. It becomes more active. So we've been working on this for about a decade. I know, you're probably wondering why it's taken so long. But we have to start with some very basic experiments to understand how this movement pattern affects the brain in healthy young adults. Then we move on to healthy older adults. Then we move on to older adults who've had a stroke perhaps years ago. And then we move right on to people who've had a stroke just within the last few days. And it actually takes about 10 years to work your way through all of those pieces of research. What we've found is that doing this for about 15 minutes, using this kind of device, takes the brakes off the stroke side of the brain, and that lasts for about an hour. So what you've done is you've created a window of opportunity where the brakes are off, the stroke side of the brain is pre-activated, and it's more plastic. That's the key. So we tested it first with people at the chronic stage of stroke and found that it boosted the effects of therapy. So we were pretty excited about that. And so we've just recently finished a trial with people who've just had a stroke at Auckland City Hospital. What we did was this. We took people, here's the stroke here. We did some baseline measurements in the first couple of weeks while they were in the hospital. Then they had 4 weeks, and they did one of two things. They either used the bilateral priming or they did a control type of priming. They did that for 15 minutes, and then they did half an hour of hand and arm therapy with a physiotherapist or an occupational therapist. They did that every weekday for a month. Then we measured them again at the end, at 3 months and 6 months after stroke. This is what the device looks like, the bilateral priming, and this was the control priming, okay? And the patients didn't know which was meant to work. They thought both would work, and the therapists were all blinded. There's a lot of science in the background. And then they went on to do their therapy. The main result is this, that priming accelerated the recovery of hand and arm function. So the green line is the patients who did this, the bilateral priming. The blue line is the patients who did the other placebo priming. And you can see that the primed group reached their best recovery much more quickly. And that's exactly what we predicted. We predicted that by taking the brakes off the stroke side of the brain, it would be more plastic and it would respond better to therapy and people would get better faster. And that's exactly what happened. It's not just good for the health service. Clearly they want people to get better as quickly as possible, but it's great for families and for patients and their families to more quickly get as good as they can be and get back to their lives, get out of rehab and back into their lives. So we're quite excited about that. So we think it accelerates recovery. It is appropriate for most patients. It's very safe. You know, it's not a medicine. It's easy for people to do and very easily administered. About half the patients actually took these home and did most of their therapy at home on their own. So you can do it on your own. We think it benefits the brain. That's how it works. It's not just therapy. This actually isn't therapy, right? It's making the brain more plastic. That's the point. And so we think it's a useful adjuvant to therapy. It can't replace therapy, but it prepares the brain so that the therapist can get the best bang for their buck out of that therapy session. That's the plan. So that's just one way that we're trying to improve recovery from stroke. Getting back to the general picture, the general scheme, right, it's to pre-activate the brain before therapy. So we've talked about this approach, and the second approach is this one, non-invasive brain stimulation. That looks awfully invasive, but it's just a graphic. So there's two ways to do this. There's magnetic and electrical non-invasive brain stimulation. Both of these look slightly scary, but in fact it's quite safe, it's painless and completely non-invasive. For the magnetic stimulation, which I'm going to tell you about, we just use this plastic device here, and it just gets held gently against the scalp, and when it goes, it just makes a click sound. It's actually more of an auditory experience than anything else. All right, so the good thing about these techniques, the brain stimulation techniques, is that we can target them to specific areas of the brain, and we can also use different protocols that can either increase activity in the brain or decrease activity in the brain. And you might be thinking, well, I'm not sure why you'd want to decrease brain activity. That actually doesn't sound so good to me. And you'd have a point, but there's a specific situation after stroke where in fact that's a very good thing to do. So here, we're looking at someone from behind. They've had a stroke. It's this little black spot up here. And this is to illustrate the idea of balance between activity in the two sides of the brain. Wow, that was bad. Don't touch that button. There we go, and we're back. Whew, okay. Whew. All right, this button. So after stroke, the control of the opposite side of the body is disrupted by the stroke. So the dotted green line means the stroke side of the body, stroke side of the brain, finds it more difficult to control the opposite side of the body. But the other thing to think about is those connections between the two sides of the brain. Remember the ones I told you about, which sort of let you do opposite things with your hands or the same things with your hands? The two sides of the brain actually talk to each other all the time through a big bundle of connections right through the middle. So both of those outputs are disrupted by stroke. Whereas the good side of the brain can still talk to the body, no problem. It can also inhibit, that's what the red arrows mean, it can also inhibit or put the brakes on the stroke side. Okay, so this is out of balance. There's a real asymmetry here. So the problem for the stroke side of the brain is that it hasn't just had a stroke, it's also being actively suppressed by the good side of the brain. It's a double whammy. How's it meant to get out of that? right? So one approach, if you're looking down from the top of the brain, the activity in the motor areas might look like this. Not a lot on the stroke side and quite a lot of extra on the opposite side. And we know from our own work and that of colleagues around the world is that a good recovery is associated with balancing. Basically, the more normal your brain is, the more normal your movement will be. It's not rocket science, is it? So what we can do is use these brain stimulation techniques to either turn up the stroke side of the brain or turn down the opposite side of the brain, right? And you can see, I hope, that if we do that, we're going to reduce this inhibition. We're going to reduce the amount of suppression of the stroke side of the brain being put on it by the good side. And the idea is to move the brain back towards this, nice and balanced. That's where most of us are at. That's where we want our patients to get to. So we've been looking at this with a particular type of magnetic stimulation called theta burst stimulation, TBS we call it. And we asked the question in a study we've just completed, well, this particular study we completed a couple of years ago. We asked, can we improve precision grip in people at the chronic stage of stroke by combining this magnetic priming technique with practice, right? So remember, the priming on its own probably isn't going to do anything, but it might prepare the brain to have a better response to practice. So we only looked at 10 patients because we just needed to know if there was anything there for us to carry on with. And what we did was this. We tested their precision grip with a special device that lets us measure how much force they're using. So how hard do they squeeze it? How fast do they lift it off the table? We then primed the brain, got them to practice a similar but not identical task, and then tested them again. And we actually used 3 different kinds of priming. We used one kind of priming to turn up the stroke side. Then in a different session, we used another kind to turn down the good side to try and get that balance back. And then we also had a placebo type of priming, and the patients didn't know which was which. So what did we find? Well, we measured a couple of important things. One was, how long do people pause before they lifted that thing off the table, that instrumented device? When most of us pick something up off the table, we just do it. Bless you, bless you, bless you. We don't really have to think about it, do we? We just scoop it up and there it is, and we're very lucky that that comes so naturally to us. What we know is after stroke, people do something a little bit different that we can only pick up by measuring it quite carefully. They touch, pause, hold, engage. I always think of rugby when I tell this story. They do. They touch it and they pause before they lift up. And during the pause, they actually push down before they lift up. So we measured those 2 things. We touched how long do they pause for, and while they're pausing, how hard do they push down? Because those are 2 sort of hallmarks that their precision grip isn't quite normal. It's still affected by stroke. So we measured those things. What happened? In a nutshell, practice alone, so if they just had the placebo priming, they actually got a bit worse. They paused for longer and pushed down harder. And we think that was simply fatigue because they had to do quite a few trials. But if we primed them first, they were quicker at picking it up and their force was stable. Right? So we actually improved their performance of just a simple task like that. So what we think is that the priming prevented the effects of fatigue. They were able to practice with better quality movement for longer, and this meant that their practice was more efficient. And that was just a simple proof of principle study, but it was published in Stroke, which is actually the world's leading stroke journal. So we're very proud of that result. And I should mention here that that entire study was funded by the Neurological Foundation, not just the project, but also Suzanne Ackerley. This was part of her PhD. She's a physiotherapist, and they supported her through a Miller Scholarship throughout her doctoral studies. So none of this would have happened without the Foundation's support. So what are we doing now? Well, now what we're doing is we're doing multiple sessions over 2 weeks. We want to know, if you do primed practice sort of frequently, do you produce a lasting improvement in the way people's hands and arms work? And we selected one of priming techniques, so that's to increase activity on the stroke side. And then we test them again. Now, we're just in the process of crunching the numbers on this, but I'm going to give you a sneak peek in a second. The strengths of this kind of approach is that we've got options. We can either increase activity on the stroke side or decrease it on the opposite side, so it's a very flexible approach to priming. The limitations are it does require some specialised equipment, which isn't cheap, and some people can't have this. For example, if you've got a cardiac pacemaker, you can't be in a magnetic field. You can't have an MRI scan, you can't have magnetic priming. So it's not suitable for all of our patients. But despite this, we think some will benefit. So as I said, right now we're looking at repeated sessions to see if we can produce a lasting improvement. And I think you're the first people in the world to see these data. This is the sneaky peek. This is just our initial analysis. You can see in the blue, these people had this was half the group, and they had the real priming, and the people in red had the placebo priming. And you can see that the people who had real priming had an improvement in their hand and arm function. This is a number of points on just a validated scale of hand and arm function that we use after stroke. So they improved immediately after the 2 weeks, and that was sustained. This follow-up is actually 3 months later. So they got quite a lasting benefit from the primed therapy, which the people who got placebo priming, but the same dose of therapy, didn't achieve the same benefits. So we think we might be onto something. And what we're really interested in is can we take people at the chronic stage of stroke, give them short bursts of therapy, boost their brain's response with priming that might sort of set them up for at least a few months of better function. And maybe that needs to be repeated once or twice a year for people forever after stroke. Maybe that's the way to help people stay as good as possible after stroke. So we're pretty excited by that. But it's still a work in progress. We have a pile of data still to work through. But I thought you'd be interested in the main result. So I've shown you a couple of priming techniques that we're working on that we're pretty excited about. But it's not one size fits all. Nothing is. That's why we're working on a range of priming techniques, because there's not going to be one thing that can help everybody. So the next question is, how do we pick the right priming technique for an individual patient? First, we actually have to be able to predict their potential for recovery, and that's a really difficult question. I'll show you how difficult. This is a graph that we published a couple of years ago. Along the bottom is time since stroke in months, and up this side is something called the Bartel Index, which measures how independent you are in looking after yourself. And a high number is good, right? Higher the better. And you can see each of these little dots here in different colours. The blue ones are people who only had movement problems after stroke, nothing else. Whereas the light blue ones meant that they had movement and sensory problems. The purple triangles mean that they had movement and vision problems. And the green triangles had movement, sensory, and vision problems. And you get the general idea, don't you, that the more sort of things that are affected by the stroke, the sort of overall worse off you are. It's harder to be independent if you've got problems with movement, vision, and sensation compared to only having movement problems. But here's the real problem for us. Look at how much these groups overlap, right? So you can have someone here who has movement, vision, and sensory problems, and they're actually doing much better than someone who only has movement problems. So you can't really tell from just looking at a patient how well they're going to do in terms of their independence, right? Everyone's a bit different. Just looking at the hand and arm, because that's really my particular interest, along the bottom here we have a scale which looks at a very simple thing. It just tests, can you achieve and maintain this posture with your weak arm? That's all it is. And this time, just to confuse you, a low score is better, right? So 0 means you're perfect. 4 means you can't raise your arm off the bed. So if we look at the people who scored a 2 quite soon after stroke, and then look at how they were doing 3 months after stroke, this time a high score is better. They could be anywhere from 0 to perfect. So if I look at a patient in the bed, see if they can do this, score them a 2, it tells me nothing at all about where they're going to be in 3 months' time. It's really hard for therapists and clinicians to really know with any accuracy where people will end up. We can know in general terms, but for individual patients, these predictions are very difficult. And they're important to get right because we don't treat groups of patients. We treat individual patients, and we need to know more about them And to do that, we need to know something about their brains. So the final thing I'm going to tell you quickly about is the work that my group is doing, trying to figure out if we can make better predictions, more accurate predictions for individual patients. So we're seeing whether a couple of our sort of more research type tools might be useful here. So things like brain stimulation and brain imaging. The idea is that recovery happens in the brain. It doesn't happen in the arms and legs, it happens in the brain. And so if you want to predict recovery, you might need to know something about the brain. It's a pretty simple idea. So how do we do this? Well, one way is to test what we call the functional integrity of the pathways. How easy is it for a movement command to get from the brain to the body? We can test that very easily using that magnetic stimulation technique I told you about. It's simple. You just stimulate here and see if you get a response here. Can the message get through from brain to body? If the answer is yes, you're obviously in a better position than if the answer is no. It's quite simple. Another way to do it is to use an MRI scan and look at the structural integrity, to look at exactly which pathways in the brain have been damaged and how badly damaged are they. And here we're quite interested in this bit, the internal capsule. I've just sort of put the blue boomerangs on so you know where to look. These are like the telecom cables, right? So you've got a big surface area on your brain which organises your movement plans and then sends the command to your body. And that command travels along connections through this part of the brain, the internal capsule. And they're all bundled tightly together, like a big cable taking the messages to the body. Right? If we map them, then we can see that the different colours represent different areas on the surface of the brain that we're interested in. Right? The posterior limb, the back part, is the one we're most interested in, and the orange and the blue bits are the ones that take your movement commands to your body. You can see that it's a tiny, tiny piece of brain, but it takes all of your movement commands to your body. So even a tiny bit of damage here is going to make controlling the opposite side of the body very, very difficult. And I'm just going to point out how much that looks like a map of New Zealand. Did you guys see that? Yeah, I know. Isn't it weird? I mean, the authors of that study are somewhere in Europe, and I don't think they had any idea they were drawing a map of New Zealand when they organised that figure. And I always point this out when I'm talking at overseas conferences that, you know, we're it, clearly. Well, the mainland is, at least. Anyway, we digress. Okay, so we have some pretty neat tools for visualising these connections, visualising these pathways using MRI. And so here's an example here. The brownie bits are those internal capsules, those particular areas of interest. This purple bit here is the stroke, right? And you can see that it's just nicked the edge, hasn't it? So if you look up, there's sort of a gap here where there should be more fibres. So the stroke's definitely damaged some of the connections between the surface of the brain and the body. A more startling example is this. So this person's had a huge stroke here in purple, and there are no connections left. There's no way for that side of the brain to talk to the body because all of the connections have been damaged. And this one I really like, and I always keep in, because it's the great escape scan. This person has had quite a big stroke, but it has somehow just skimmed the edge of these connections, and they're intact, and this person made a great recovery. Okay? So that's to illustrate that the size of the stroke doesn't actually tell you the full story. You need to know exactly which part of the brain it's affected to really know how that person's going to go. So how can we use this information? Well, we can combine it. So here are the responses to the magnetic stimulation. Patient 2 here, this is their good hand. You can see a nice big response. And this is their weaker hand. It's a smaller response and it's slower, but it's definitely still there. So we can still get a message from the stroke side of the brain to their weak hand. That's good. On this side, patient 11, good response in their good hand, but we couldn't get anything at all from their weak hand. We weren't able to get a message through. If we pop them in the scanner, this is what we see. So here's patient 2, a little bit of damage on this side, but not too bad. Whereas patient 11, you can see quite a bit of damage, but there are still a few pathways left intact. Now, it shouldn't surprise you to hear that patient 2, their scores for how their hand and arm were going were twice as high as the ones for patient 11. Patient 2 is definitely in a better position. But you know what? After a month of therapy, they both improved by the same amount. Right? So just because patient 11 started from further back, doesn't mean that they couldn't improve. They could still improve. And we think that was because they still had just enough connections left to be useful and make some gains. So we're now combining all this information in something we call the PrEP algorithm. PrEP is for predicting recovery potential after stroke. And what we do, we're testing this right now in Auckland City Hospital, is we test them soon after stroke, only 72 hours, and we have a look at what they can do. We look at a couple of movements called shoulder abduction and finger extension. That's how we get the acronym SAFE. And we score it just using a very simple clinical scale. People who score well, score at least 7, we predict they'll make a complete or near complete recovery of hand and arm movement within 12 weeks. People who don't, we then use the magnetic stimulation to see, well, can we get a message through? Can we get anything from here to here? And if the answer is yes, we predict they'll make a significant improvement. They might not be perfect, probably not perfect in 3 months' time, but they'll be doing very well, and they will be using that hand and arm for normal activities around the house. People who we can't get a response from with the magnetic stimulation, we pop them in the scanner, give them a ride, and we just look at those pathways through the internal capsule, and we look at how asymmetric they are, right? How different are they? Don't worry about this number, that's not too important, but people where the asymmetry isn't too bad, we predict they've got capacity to make a limited recovery. They will get some movement back, but it probably won't be that useful to them. Whereas people who are very asymmetric, they've sustained a great deal of damage to those critical pathways. We predict that actually really they've got no potential to recover their hand and arm function. And that sounds quite grim, I do understand that, but that is the reality for some of our patients, and we'd rather know that and treat them accordingly and help them sort of learn to compensate and adapt to that as quickly as possible, than perhaps try to do lots of therapy with them that ultimately isn't going to help them. So how do we integrate the two things? Well, we think, oh, no, don't. Sorry, getting away on me. Okay, so we think that people here who have significant potential, we should be priming the stroke side of their brain to help it become as active as possible, respond as well as possible to therapy, and make the best possible recovery. Whereas people who have limited potential, we think perhaps we should be priming actually the stroke side of the brain for adaptation, right? They're only going to get limited movement back. Whereas people with essentially no potential for recovery, rather controversially, we think we should be priming the opposite side of their brain. So to help them learn as quickly as possible to do all the things they now have to do with their good hand. Right? So you can see how these two things together, predicting recovery for individual patients, also can help us choose what the goals of priming should be and how best to shape their therapy for the individual person. Okay, so here are the take-home messages. Practice changes your brain throughout your life. Whatever you do, experience, think, practice often, daily, it's changing your brain. Right? So think about that. Think about the things you do most often. They are changing the strength of connections in your brain. And that's thanks to plasticity, and that is how we learn and remember, and it's how we recover from injuries such as stroke. Priming techniques like the two I've described today are being developed by our group and others around the world to promote plasticity, to help the brain recover as well as it possibly can after injury like stroke. And we're also at the same time developing these prognostic tools so that we can match the right priming techniques to individual patients based on what's actually happened in their brain. Because we can't really tell just by looking at patients what their potential is. We need to know something about their brain to make an accurate prediction. My dream, if I can be so bold, is that rehab in the future will look like this. People will come in for rehabilitation, and we're going to assess the brain's capacity for recovery. We're going to test the pathways using stimulation and imaging techniques. We're going to check the genes. We haven't even talked about genotyping today, but that's coming. And we're going to increase the therapy dose for those with good potential. And we're going to set realistic therapy goals with patients and their families right from the beginning. We're going to select the most appropriate priming technique to boost the response to therapy. And we're going to provide ongoing rehabilitation prescription so that we can monitor self-directed rehab. Because once people leave formal rehabilitation, they have to keep working just to stay still, right? And there's so much more that we can be doing to help people retain the gains they make in rehabilitation by helping them continue to practice, continue to work on their recovery for the rest of their lives. And the focus has to be on changing the brain. We're not treating arms and legs, we're treating brains. And that really needs to come through in the way our therapy teams think about their work. And it is starting to become a reality, I think, this dream. The University of Auckland now has a brain recovery clinic, of which I'm the deputy director. It's a research clinic, and it's there that we're able to bring some of these new techniques and ideas into practice with real patients in the community. And if you'd like to know more about that, you're welcome to email us there. Finally, I'd just like to acknowledge that everything I've presented to you today is a team effort. I'm just the lucky one who gets to come here and talk to you good people about it, but I've got a wonderful team of people around me, and we're supported very generously by the Neurological Foundation and also a range of other funding sources within New Zealand, and we just couldn't do any of this work without the support of these people and one another. And finally, I'm going to leave you with this. Thank you.
Thank you, Cathy. How well coordinated are you with other hospitals in terms of them sending information through to you to get better prognosis of stroke patients around New Zealand?
Yeah, thank you. It's a really good question. The study that we're doing at the moment at Auckland is to validate the algorithm, to make sure that we're right and to tweak it. You know, this is important information. It has to be right before we can roll it out. But part of that project is going to be to start paving the way to get those prognostic techniques into other hospitals and other DHBs. So we're quite well connected with other DHBs, with the rehab communities, but don't feel quite ready to take this to them. We're still refining it within our own environment, and then once we feel quite confident with that, then we hope to roll it out more widely. Yep. Yeah. So the question is, can you do this by hand or do you need to use the machine? The machine makes life just so much easier because people after stroke often are very weak, so they can't just sort of sit there and do this themselves. And for it to be effective, we think you do need quite a high number of repetitions. So, we get asked occasionally, well, could my, spouse or the therapist move my hand for me? Sure, but they're going to get real sick of that in about 2.5 minutes. So what the machine does is it lets people do it at their own pace for much longer periods of time without getting tired to get the necessary dose. I think the other thing too is that even a very switched on therapist or spouse would find it hard to get into a perfect rhythm where it's perfectly symmetrical. And so the machine does that for you. It has to be perfectly symmetrical. So I think the machine just makes your life easier. Yeah, so the university has this thing called Uni Services, which is a commercial arm, and they're in the process now of finalising a patent so that it can be produced commercially, and they have a manufacturer in mind. So we're working on that and hope to be able to make it available sooner rather than later. Yeah. I certainly am. Yes. Yes. That's right. So the question is about how this relates to use of a mirror box. So for those of you who perhaps haven't seen one of these, it's where you pop your not as good hand inside a box with a mirror here, sort of on your midline. And when you move your better hand and look in the mirror, it creates an illusion that your weak hand is doing exactly the same thing as your good hand. I've got that right, don't I, sir? Yeah. And so that, we think, is probably doing something quite similar through the visual system. Through the visual system. And the visual system has lots of inputs to the movement system. Where this is slightly different is that you can see it yourself. You don't need a mirror. You can see that your hand is moving in that mirror-symmetric way, and it creates all the sensory information as well, which of course you don't get if your hand is still inside the mirror box. So we think it uses similar principles, but perhaps might add a bit because of all that extra sensory information it provides. Yeah. You're welcome.
How much does greater age influence the likelihood of recovery?
It's a really good question. With greater age come often other types of other health problems. So it's a hard question to answer, and I am sort of hesitating because on the one hand, people can recover well from stroke at any age, right? We do see that clinically. On the other hand, if you look at big groups of patients and you look at them statistically, then there is a suggestion that the older, and I do mean the very old, the sort of 90s, 85s, 90s and over, I don't mean, young old, which is the 60s and 70s in my view. The older I get, the younger we all are. So there does seem to be, when you look at big groups of patients, that the oldest of the old perhaps don't make as good a recovery. But you have to remember that there's lots of other things sort of working against them at that time. So it's hard to know. If you could look at people in their 90s who had no other health problems other than the stroke, might they do as well as someone 20 years their junior? It's really hard to tell. Yeah.
Excuse me, could you wait for the mic, please?
Yeah.
Hi, that was a really interesting talk. Thank you.
You're welcome.
I was wondering, you talked about the non-invasive and the coordinated stimulation, but you didn't talk much about what the pharmaceutical agents were.
Yeah. Yes, that's right, because we can't be here all day. Would you like a quickie précis?
Yes.
Okay. Drugs. Okay, there have been a range of drugs tried to help people recover from stroke. Some of them you might be familiar with, things like dopamine, which is actually a Parkinson's disease medication. Some that you might be familiar with for other reasons, amphetamines. Yep, speed. Whoa, yeah, I don't know. But some more common ones are things like, there's a class of drugs called SSRIs, so that's selective serotonin reuptake inhibitors. It's actually a form of antidepressant. That's the most common reason that those drugs are prescribed. There was a big study came out 2 years ago from a group in France, and they gave people who were quite moderately to severely affected by stroke either 90 days worth of this antidepressant, fluoxetine it's called, or a placebo, and they started this within a week of stroke. They got to 90 days out, had about 120 people in the study, and the people who had taken the actual fluoxetine were better off with their movement than the people who hadn't. Here's the problem. The people who took the antidepressant were less depressed. Good, the drug actually works, super. But the problem here is that people who are less depressed often will work harder in therapy, right? So people who experience depression after stroke, and it is quite common, as I said, often what that does is it demotivates them and they don't engage in therapy as much. And because the authors of the study didn't measure therapy, we've got no way of knowing. Is it the drug's direct action on their brain that helped their brain recover, or is it simply because the drug did what it's meant to do, which is to make them less depressed, and because they were less depressed, they felt more engaged in therapy and worked harder, and it was by doing more therapy that they got better? See the difference? Yeah. So it's tantalising. We'd love it if there was a simple medication that's already in use that has very few side effects, that people tolerate really well, that could somehow boost the effects of therapy, but we're actually not there yet. I don't think we have really good trials to tell us whether that's possible, and if so, which drugs we should use. So that's why it's further back than these other things that I've talked about today.
Here's a microphone behind you, sir. Cathy, does the research unit in Auckland do any work on recovery of visual hallucination following a stroke?
Gosh, that's an uncommon symptom of stroke. Visual problems after stroke are quite common. Hallucinations are less common. I don't personally work in that area. I'm more interested in the control of movement after stroke. But it it's fascinating, and I'm sure someone somewhere is paying attention to that particular problem. I suspect that the similar principles will apply, which is that the brain has changed thanks to the stroke, and through priming techniques and therapy, you know, there hopefully is a way to get it to change again so that those symptoms are minimised. That would be the hope.
Okay, thank you very much. Can you hear me, everyone? Yeah. We'll have to leave it there for now, as we have gone a little bit over time, but I'd just like to say thank you again, Dr. Cathy Stinear, for your incredibly interesting insights into the world of clinical neurology and the very practical applications that you're working on. And thank you for taking time out of your really busy schedule to join us here today. So if everyone would just like to join with me and thank you.
Thank you.
And to you, the members of the audience, thank you so much for coming along this morning. I'm sure you've all gained something out of today's discussion. Just a reminder, if you didn't register when you arrived, or if you didn't hand in your registration, please do so when you leave. The other thing that we've got out in the foyer is a certificate of attendance. So if you work in the medical profession and you would like a certificate to say that you attended today, then we can give that to you. So please just ask us at the registration table outside. So I'd also like to make a special thank you acknowledging Mitre 10 for their long-time support of our annual appeal. Also to our wonderful volunteers who we just could not put these events on without. Also to the local community support groups who support the Neurological Foundation. We do work a lot together and they can provide very practical support services to you and your community, and particular mention to the Stroke Foundation. So thank you, Julie, for coming along today. So we look forward to bringing you more about the wonders and achievements of brain research in the future. So once again, thank you very much, and please join the Neurological Foundation and help support our best researchers today. Thank you.